gang, welcome back to the video. If you are new here, welcome, and if you're back for another video, thanks so much. So as you guys know, here on my channel we do videos on beauty, nursing, and lifestyle, and today is the mood for nursing video. So today I'm going to be telling you guys a little bit about what I do at work, and by saying that I mean most of you guys know I am a telemetry nurse. That is where I grew up. And when I say grow up, I mean that is the unit where I kind of got all my feet and all my wings. I started as a new grad. I've been on this unit for about 2.5 years, I think it is. Yeah, I think it'll be 3 in the summer. And I have not left despite all the craziness that goes on at my job. So I want to tell you guys a little bit about what type of patients we get as telemetry nurses. So if you guys are interested in this video, please stay tuned. We're going to jump right into it. This is my general warning here first. This video is for a general audience. So even though I am a medical professional, I will not be using medical jargon or medical terminology throughout this video. Of course, when I'm saying the diagnoses and what they are and other things, I will use medical terms, but I'm going to try to keep it as layman's as possible because I know this video is for a general audience. So if you are a medical professional, do not drag me. There's going to be a lot of comparing, what am I trying to say? Not necessarily synonyms, but I'm going to be using a lot of layman's terms or general statements to represent what's really happening in the body with the heart, etc. So first things first, telemetry, what is it? It's heart monitoring in a nutshell, point period blank. You have some type of diagnosis which is requiring you to be on a heart monitor, but not only be on a heart monitor, it's requiring the professional that's taking care of you to know what to look out for on that monitor, or to know what would be a suspected intervention for what would be occurring on a monitor. So let's jump into the diagnoses. The first one is chest pain. Pretty self-explanatory. Many of you guys know, even if you're not medical professionals, chest pain isn't always a good thing because there's obviously the first thing we think, is it a heart attack? Not always a heart attack, but we always assume the worst when you come in with this symptom because we want to rule, if anything, we want to rule out the heart and work to the next step. But if it is the heart, we want to catch it in time so you don't have any detrimental effects afterwards. So chest pain, you need heart monitoring. You're going to come in and get an EKG, of course, but you need to be on a heart monitor nonstop because we need to make sure this chest pain isn't going to bump you into any rhythms that are detrimental to you. Chest pain can mean a lot of things. Again, I already mentioned heart attack, where you would go to a cardiac catheterization lab, or you would have to get stress tests done and other cardiac diagnosis tests done to determine what is really the cause of this chest pain. But in general, you're going to come to my unit because we need to be able to monitor you. We're going to draw some labs, see if your cardiac muscle's been affected. We're also going to keep you on this monitor, look at where different waves are, make sure there's no changes in your rate and everything like that, and overall making sure you're not trying to convert or already in a rhythm that is detrimental and requires emergent care. And if it does require emergent care, we do take a course called Advanced Cardiac Life Support, which basically warns us what would be the steps in general to do if people do get into these detrimental rhythms. So chest pain is pretty much self-explanatory. It's neither here or there because now my hospital there's administrative stuff going on. I don't even want to talk about it, but chest pain, if I see a chest pain in the ER, most of the time it will come to us unless it's something that requires critical care immediately or it's a rush to the cath lab. So that is the first diagnosis. Number 2 is something called Afib, and we usually get patients that either have new onset Afib or have a history of Afib, and they're either uncontrolled or rapid. So for layman's terms, I best explain Afib to people as your heart is supposed to do a lub-dub. It's like a synchronized movement, and this is how you're getting blood out and getting blood in to the heart, pumping stuff out to the body that's needed and taking in what you need to recycle. So when your heart is doing this synchronized movement, it's keeping everything under balance. When you have Afib, your heart is like a ping pong machine. It's doing all this. It's moving all types of ways. It's doing all types of quivering. The rhythm is out of control, and your heart is not only having an imbalance, but because it's doing this quivering, the heart, some of the blood is not always moving the way it's supposed to, and it's exposing you to the potential of having a clot. And if any of you guys have heard of a clot, even if you're not a medical professional, you know it's not a good thing. And most of the time, our clots are what cause our strokes. So that's why we worry about people who have what is called Afib or atrial fibrillation. Basically, these patients come to us because we need to monitor this rate at which they're having atrial fibrillation. We know about the interventions. Most of the time, we're going to either prep you for an intervention that's going to be needed, whether they're going to try to convert you back, whether you convert on your own to a normal rhythm, or whether we are just aiming at primarily getting you in a controlled ping pong state. Because at least if you're controlled, the heart can keep up. And then we can also use blood thinners to decrease the rate of stroke because we'll keep your blood thin. But if you're ping-ponging out of control, crazy nonstop, heart can't keep up, and that is an issue. So in general, second diagnosis, new onset AFib, or people who have AFib that's just out of control and we need to kind of get a handle on it. We do have another unit on our hospital that takes these patients if they need to go on certain type of drips, but on my floor specifically, we can at least take them if they're at a steady rate on a drip, or we can also take these patients if they're on an anticoagulation drip, and that anticoagulation drip is known as heparin. Bing, 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 bing. Number three, y'all, is CHF. What is CHF? Congestive heart failure. You've probably heard it even if you're not in the medical field. Congestive heart failure, why does it warrant you to be taken care of by a telemetry nurse? That is another one that's here or there. Telemetry nurses are taking care of patients with acute exacerbations for congestive heart failure because your heart is a pump. Your heart is a plumbing system. When there's issues with the plumbing system, there will be issues with how the heart can stretch and how the heart can contract. So, therefore, if there's issues with how the heart can stretch and how the heart can contract, that's going to affect the electrophysiology of your heart. You're not going to be able to always have the correct rhythm sometimes when you have either a fluid overload or things like that. So in general, we do take care of patients with congestive heart failure, and most of the time we'll put them on a monitor to, again, make sure they're not going into these detrimental rhythms which will warrant us to take emergent action. What we also know about these patients with CHF is it's not only a heart problem, it's also issues with their breathing. On our floor, we know these patients also like the back of our hand, so we know what medications like diuretics or medications that get rid of fluids to kind of get these patients rolling on, what type of interventions are needed to help them with this breathing, because again, it's not only a heart problem, it's also breathing. There's a lot of systems that can be affected by congestive heart failure, but in general, telemetry nurses are taking care of these patients because there is a potential for them to go into rhythms that are not so warranted, and we need to know what to do and what to do fast in order to make sure these patients can get through this acute exacerbation and keep them alive and try to get this fluid off them in the end and get them back home. The last diagnosis is quite obvious, but just in general, we are taking care of patients who have electrolyte imbalances. So most of the time, if I'm looking at the ER list and I see that somebody's potassium or magnesium is off, I automatically know they're probably going to come to our unit. And one thing this usually happens, and this is a story I've been hearing from tons of my patients lately, is I'm going to the doctor's office for a general checkup. I'm either getting an EKG or I'm getting some labs done. And what happens is something don't come up right. Something comes up a little abnormal. And because we know potassium and magnesium are heart electrolytes, all your electrolytes are important, but these two are important for your heart. If there's issues going on with them, or if you're getting EKG done and you have a rhythm that's not norm, they are going to warrant you to go to the hospital, because if for any reason you go home, this rhythm changes, or if you go home and these electrolytes don't get back in balance, there is potential for detrimental effects. So that is another reason we take you in, we put you on a heart monitor. What's your crazy rhythm? What do we need to do to fix this rhythm? What's going on with your electrolytes? Why is it going on with your electrolytes? We can replenish or we can get rid of as much electrolytes as we can, but in general, most of the time these patients I don't want to say they're complicated, but we have a lot of other systems going on because we really have to figure out why their electrolytes aren't right. Are they a dialysis patient? Is there something going on with their kidneys? Is there something going on anywhere else in the body that is creating either too much potassium, not enough potassium? Are they on a diuretic? Are they getting rid of potassium when they get rid of their fluids? These patients, although it's such a simple diagnosis, I have found myself critically thinking about these patients the most because I'm trying to figure out why are their electrolytes not right. I know we got to treat the heart, and I know we got to make sure their heart is safe, but what is causing this to happen in the first place? Okay guys, so in general, we've talked about 4 diagnoses. We've talked about chest pain, we've talked about new Afib or our ping pong rhythm, we've talked about congestive heart failure or our plumbing problem, and we've talked about electrolyte imbalances / dysrhythmias. So in general, these are usually my 4 top diagnoses as a telemetry nurse. Most of you guys also know my unit is telemetry neuro, so I also take care of patients' seizures, TIAs or mini strokes, and of course people who have strokes that don't warrant intervention. And I can do a video on that if you guys are interested in that also. But in general, these are the type of patients I'm taking care of as a telemetry nurse. It is not limited. My floor has gotten more I want to say broad, especially within the last couple years. I take care of med-surg patients. I take care of patients who don't even need heart monitors half the time. But in general, if somebody is warranting telemetry monitoring, they are getting sent to my unit to be taken care of by me and my colleagues. So in general, guys, I want to thank you so much for tuning in. If you have not already hit that subscribe button, hit that thing. What you waiting for? Make sure you like, comment, subscribe, thumbs me up. Hit the notification bell at the bottom. If you're a nurse, whatever your specialty is, comment down in the comment box below. Let me know what are your top diagnoses. I love watching these videos because it just kind of gives me more knowledge. And once again, let me mention, just as a disclaimer, if you are a medical professional, please remember this is a generalized video, so a lot of our medical terminology is not used in this video, and of course physiology, pathophys, and everything like that won't be up to par because I just want to make this a generalized video that somebody who is random out in the public, not even in medical, can watch and still understand. So in general, guys, thank you so much for tuning in. I'm looking forward to seeing you guys in the next video, and don't forget to subscribe and like on your way out. I'll see you guys next time.